that we hope will be part of a discussion. So I'm a colleague of Professor Simon Kambo. I met him when I first came to Uganda approximately 15 years ago. So I've been part of the MEPI project and then Afri Health, and I'm a big fan of Uganda and all of the good things that are going on here. We're learning a lot from the good work that is going on in Uganda. About 3 weeks ago, Professor Simon Kambo visited us at the University of Michigan. Have any of you been to the University of Michigan before? Okay. So here's an open invitation. You're welcome. All right. I'd like to see as many of you as possible at the University of Michigan. Let me say a little bit about our institution. But when Professor Simon Kambo was there, he said, when you visit Uganda next, will you speak to us about how you're thinking about interprofessional education? So I said, well, we will, but I think we have as much to learn from you in your activities. So we hope to start a conversation here that you will inform us about the things you're doing with interprofessional education. So I'm joined here with Professor Brett Williams, who is a director of our Global Health and Disparities Path of Excellence. He also is a medical director. He does a lot with interprofessional education and practice, and is a professor of our general internal medicine. So the format is that I'm going to say a few words about the University of Michigan. I'd like to ask you a few questions to try and understand who's in the room. I'm one of these annoying dean of education types who always likes to do the needs assessment and find out who is in the room, what questions do you have before we head out on our journey. But then Brent is going to get into some of the nitty-gritty about what we're actually doing. I think what you'll hear is our overall thinking or approach to interprofessional education. But what we're hoping to hear from you is a little bit more of the nitty-gritty, because you have a very specific project on interprofessional education. How many of you are actually involved with that project, the SPREAD project? So a lot of people, but not everybody. Okay, all right. I've heard a little bit about that because I was at the Afri Health meeting in Nigeria. So how do I change the slides? Right up there. Okay, and I want to be a famous man. I want to be a big man. How can I be positioned for you correctly for the video? Stand here. Okay. All right. So Michigan. So we come from the University of Michigan. Where is Michigan? All right. A lot of people, when they come to the United States, they're used to going to the East Coast, New York. They're used to going to California, UCSF. We're in the middle of the country. We are in what's called the Great Lakes State. Because the Great Lakes, we have 5 Great Lakes that are like Lake Victoria. Lake Superior is always rivaled with Lake Victoria. One's got more surface area, one's got more water. All right? But we're similar to you in terms of a Great Lakes state. So we do a lot of things in the water. So you see our beaches, you see our lighthouses. It's very pleasant looking. This is the lighthouse, but that's not how it looks right now. We're heading into the winter. So in the winter, we're up north there by Canada, so it looks like this. It gets covered with ice. All right, you can walk on the water. You can't do that on Lake Victoria. You can never walk on Lake Victoria. But in our lakes, you can walk on, all right? So those of us from Michigan are very, very happy to be here in Uganda this time of year, all right? It's the worth of the climate, the warmth of the people that we're very, very happy about. So University of Michigan is in a small town. It's called Ann Arbor. This is our town, all right? The town is about 100,000 people. And it's the city, but a lot of this is our university buildings. Sometimes when you go to the United States, the university, the medical school and the university are separate, but ours is all together. This is our health campus, all right? So that gives you a sense of where we live. This gets covered in snow. We've already had our first snowstorm that's closed the schools, all right, where our kids go to school. So that's our town of Ann Arbor. What kind of university is the University of Michigan? We're a big public institution. In the United States, when people think about universities, they think of public or private. The private schools are the ones that often are more famous outside of the United States. So there are things like Harvard, Johns Hopkins, Duke, Stanford. Those are all private schools. So we're a public school. UCSF is a public school, but UCSF is only medical. We're a comprehensive university. All right, so we're a public school, and these are our values. We do research, healthcare, education, all around knowledge. We're the top public research institution in the United States. We have a lot of graduate programs. We have about 1.5 billion in annual research expenditures. And relevant to today's talk, we have a strong culture of interdisciplinary collaborations, many interdisciplinary research institutes. So we believe there's a science of collaboration and how we partner and how we work together. One of the things we're most famous for is we have the first teaching hospital in the United States. All right? So this was back in 1869. People used to think, well, you go to medical school, you go in a classroom, and once you're done with the classroom, you go out and practice. But in the mid-1800s, we were the first place in the United States to create a teaching hospital. It didn't look like this, but this is our teaching hospital and research system. All right? So it's very big for US standards, but it was the first and one of the most famous. A lot of times when people come from the United States to talk in other parts of the world, people often think, well, we must think we're the best. All right? And I want to make sure that I emphasize we don't think we're the best. In fact, we know we're not the best. The United States has a lot of problems. We have a lot of privileges, but we have a lot of problems. And when it comes to healthcare, this is one of the things that makes people like Brent and I cringe. So this is a slide that comes from an organization that looks at all the countries in the world, and they look at life expectancy and how much money we pay. So the United States is, people don't live longer or live better. If you looked how healthcare is ranked in the United States, it's ranked 37th in the world. There are 36 other countries better than us in terms of providing appropriate health care and quality for their people. But where are we number one? We're incredibly expensive. Incredibly expensive. And people talk a lot in our country about value. What's the quality and the appropriateness relative to the cost? So we like partnering with other places like Uganda to learn and see if we can co-develop, but we would be the last people to say you should copy what we do. We have some things that we do that are good. We have a lot of things that we do that are not good, that you do better. So we really think this is a co-learning situation. I mentioned that I'm an education dean, so a lot of my scholarship has been trying to think about how do you improve healthcare by changing how we educate people. What's the link between better education and better health? I was very involved with, you may know this Lancet Commission, Education for Health Professionals, where we think about how is the education system structured so that we actually impact on the health system meaningfully. So that's my passion. That's what we do in MEPI, AFRI Health, and that's one of those dynamics. One of the things that I'm also very mindful of, sometimes when you hear a doctor speak, a lot of times the doctors are are viewed as the most important tribe. All right, they're the big gorillas in the room. All right, and that I think has been a real problem for the health system, because we know there are many other people that take a health system to make it work. I always like this slide, how different healthcare workers fit into a health system. And if you actually look at the doctor component, it's relatively small. But you've got these other cotters who need to come together in terms of making better health for the people we're called on to serve. So we're very happy to see this movement. And I know sometimes in the United States, we talk about this in different ways. I know sometimes when I'm in Africa, I come to Africa about 4 times a year. I know sometimes the conversation in Africa is about task shifting. You know, how can you move the care and the work into different groups? When in reality, I think we're talking more about how do we make the team work together. So this is my last slide before I actually turn things over to Brent. We just want to get a sense from you about exactly what your starting points, because I think these terms, interprofessional education, interprofessional practice, collaborative learning and practice, have different meanings. And I know, could I just get a sense of who's in the room? How many of you are trainers? All right, we've got a few trainers. How many of you are clinical people? You do clinical care. Great. How many of you are students or learners?
The residents.
All right, good, you're my kind of people. Although in my place, when I ask how many of you are learners, I expect all of you, everyone to put their hand up, okay? Because we're all learners, right? How many of you could explain what interprofessional education is? You know what that means? All right, some of you. How about the difference between interprofessional education and practice? Okay. How about collaborative learning and practice? Are these words you use all the time? Professor Seelan Combo, welcome. Good to see you. So perhaps what we're going to do now is kind of shift things over. Sometimes when Brent and I are talking about this topic, we're talking about, well, should we spend most of our time talking about what is interprofessional education? Or should we spend most of our time talking about, well, why interprofessional education? Or should we spend most of our time talking about how interprofessional education? So we're going to have a little bit of a mix of that. And again, I think we're going to start off broad because you're working on something very, very specific around HIV. But we'll talk about how we're trying to create and what the movement around interprofessional education is in the United States, but specifically at University of Michigan. So hopefully we get to some really specific questions. So with that, I'm going to turn it over to Brent, and then we're going to generate discussion. So you know how to get to your slides here. I bet this is going to be very well.
So I really appreciate being here. And it's particularly great to talk about interprofessional education. I've learned already that there are some remarkable things happening here. Just talking with Ronnie about what ICU rounds can be like here at Milagro. It's impressive. So I come to you as a person who once stood at the well and absorbed the faith of IPE, Interprofessional Education, became an agnostic, walked away from the whole idea. It seemed like way too much of a Pollyanna, idealized thing, didn't match what was happening in the real world. Certainly didn't match for a lot of my learners. But after a 10-year break, I returned. So I'm going to talk to you about kind of 4 chapters in my experience as an educator around IPE. But as I'm talking, I want you to be thinking about your experience in IPE, whether it's on the ICU or the wards or with the HIV program or the Train the Trainer program. Bring that context right into Vibrant Mind. And then we'll want to open up a conversation about what we're trying to do, what it means, how it can go wrong. I'm here to tell you about how it can go wrong and how we can keep it straight. A little bit of what we're going to try to do. A couple of definitions about interprofessional education. A little bit about history from very much from a United States point of view and my own personal journey. I've had 5 dives into the waters of IPE in terms of teaching, running a program, and you'll hear about 4 of them today. I'll give you some of my observations about teaching IPE from my setting, and then want to do some serious comparison and contrast here. So this is the definition that's most often learned. You may have heard about it. Almost every program that gets started up around IPE quotes this. Note a couple of things. It's from the World Health Organization, so it has a purposefully global framing to it. The World Health Organization defined interprofessional education as when 2 or more professions learn about, from, and with each other to enable effective collaboration and improve health outcomes about, from, and with in a collaborative practice team framework. So this concept, this definition laid the framework for thinking of IPE as a team. And I want you to think about what's implied behind that. What was the framework? What assumptions were made in creating a definition like this? It oftentimes is interpreted as a group of people who are physically gathered around each other, rounding in the ICU, doing a case conference for a tough case, discharge rounds. In fact, interprofessional care, interprofessional communication occurs in lots of contexts, not always at the same time at the same place. And it doesn't always fit with the implicit model. So in my view, I'm speaking very editorially here. This definition set off what amounted to a kind of religion, a kind of faith. In my educator circles, people talk about IPE. We have IPE conferences among educators. And it's a little bit for me like going to a faith community. IPE is, whatever the problem is, IPE is the answer. Right? Or we know the answer is interprofessional education, but we don't always know what the question is. So be critical about this, and I want you to tune your brains to this model of team-based, same point in time, collaboration. Also notice that it implies complete egalitarianism. It implies complete equality across all the members of the team. It pushes us to presume there's equality in power, in decision-making, in authority, in accountability. None of that happens in the real world of clinical medicine. So how do we reconcile that? In the US, we have a complex mix of private and public. There's no Ministry of Health in the United States. There's no Ministry of Health. It's this conglomerate. The government is part insurance company and part healthcare delivery company. Amidst that, there's a ton of private for-profit and non-profit entities in both the insurance and the healthcare delivery system. So it's complicated and very, very messy. But it was built around episodic care for acute conditions. It's fee for service, so that you get paid for, fundamentally, you get paid for doing something. And so that pushed the US healthcare system into very much an acute care focus. Let's treat the disease, let's treat the, and you can still see those foundations built into the US healthcare system. And by the way, the public health system grew up completely separately from the acute care health system. Another important aspect of interprofessional education. On the education side, our systems grew up completely separately. Basically, the professional training schools, these 5 being the most prominent, but there are others, medicine, nursing, pharmacy, social work, dentistry, live in their own buildings. And until recently, all of their training occurred completely in silos, in separate vertical bins, with very little cross-communication. And underneath that, there's competition in the workplace. In the United States, there's actual active competition for space and income and revenue that occurs between professions. There's lots of cooperation that happens too, but it serves us poorly if we ignore the realities of what drives the professions. Okay. Now enter the 21st century, where in the United States, of course, chronic diseases now dominate the health system that was built around acute diseases. An aging population is driving a tremendous amount of the health-related problems, where they're combined with functional status, social support systems, social determinants, are ever more an integrated part of how acute disease presents itself. And then finally, we have kind of large and growing disparities of access and healthcare in the United States. Some populations and groups have much easier access and better health than others. A lot of this changed in 1999, or this was at least a landmark when the Institute of Medicine, which is a large thinking group, multidisciplinary, now called National Academy of Science. And they wrote this paper, this large monograph, To Err is Human, about the quality of healthcare in the United States. And it woke up a lot of people. It posited that as many as 98,000 people a year die unnecessarily in the U.S. healthcare system. And that got a lot of attention. A couple of years later, the Institute of Medicine published a follow-up to that, which was, well, how do we fix it? And this provided, I think, one of the core anchor points for shifting and beginning this conversation about interprofessional education in a serious way in the United States. So, in this second, crossing the quality chasm, the care system, an idealized care system, was posited. It starts with the regulatory environment, the organizations, including the work of with patient-centered healthcare teams, and it put right here high-performing patient-centered teams as a core component of it. The idea from the Institute of Medicine was that if the health professionals were talking to each other better and working with each other better, we could address a lot of these gaps in what's really a very fragmented system. And they put development of effective teams as one of the core 6 challenges facing the United States healthcare system. Now, this was in about 2001. And from then, if you look at how people were writing and thinking about interprofessional education, it started growing. In the health professions education schools and through the 2000s, it started growing. And underneath it was the team care model. So I'm going to use the word the team care model to describe this one model. It's where teams of health professionals are working together at the same time with each other in collaboration, sharing information and creating a collaborative plan for a given patient, and the patient being a member of that team. So that's the most powerful and dominant model of interprofessional care, at least in education circles in the United States. And the idea behind the team care model was also that it was relatively independent of context. There's no thinking that comes right along with that model that says, well, it works in some places but not in others. It's more or less felt to be a universal good. And I'm here to challenge us to think about where that might or might not be true in order for us to deploy it most effectively to the good of our patients. Okay, let me introduce you to experiment 1 for me. So this was in the middle of the 2000s. This stuff is all coming on board. And we got a grant from a private organization, a philanthropic organization, because we knew we needed extra money to create a team-based, team model care in the context of a geriatrics clinic. We thought it would be a great place to run this out, and so we did so. And the focus was on team dynamics and communication. We did a lot of work with the students. We had pharmacy, nursing, social work, medicine. And we would have these intense small groups where they were talking about how they approach patients. Sometimes they got angry with each other, especially nursing and medicine. Especially nurse practitioners and medical folks, because they both claim the primary care space. And especially nursing and medicine, because they both claim the behavioral health space. And sometimes social work and medicine, because they both claim the mental health space. So tears were shed in these meetings with students. They were great. But I stuck this photo because this was my team. This is where I began learning about IPE, interprofessional education. It's fuzzy and terrible, but I think it still exists on the website of our geriatric center because it was such a landmark thing. So this is my social work colleague, my pharmacy colleague, and my nursing colleague. And these folks, especially this one, Rico Folk, were the ones who pushed my head into the space of interprofessional education. I came at it really with a lot of impatience. I didn't like spending a lot of time with social workers because they take so much time, right? It's just laborious. They're always talking about all the background stuff of the patient. I'm here to figure out what's the decision for the patient, what's the treatment the patient needs. And Mariko, on more than a few occasions, would pull me aside after clinic and say, Brent, you really haven't learned how to listen yet. And I would go home crushed and angry and defensive and all kinds of put out until I figured out that she was right. This is where I feel like I made important learning headway in listening to the value of our colleagues and kind of filtering it through to hear the message that is the value of the unique professional skill and wisdom that they bring. You hear this a lot from residents and students at my institution, in medicine anyway. It's too painful. Multidisciplinary rounds are like the death knell because it's wasting time. I could be rounding on my patients. So pay attention to this in your learners because we all have to, at some point, learn how to listen and see the value, and it takes work and time. So we learned a lot through this experiment number one in geriatrics education. We wrote about it. We got famous for this article. No, we didn't get famous. I'm not sure anybody read this article. But we put it in the public space because it helped us identify that to keep this intervention going, we found that critical elements included leadership, a culture that supported interdisciplinary care. Scheduling turned out to be almost the death knell for all of us. Learner schedules are a huge problem. And then the nature of the teaching team members has to be right. One of our teaching team members from nursing just really didn't work well in this space. She was kind of curt, short, and didn't work well with the learners, and so we had to actually shift our team a little bit. And then finally, the learners. Our learners, many of them loved the intervention in geriatrics. Some of them didn't like it at all. They found it way too laborious, or they just found like, from the medical side, they just felt like the nurses or the social workers were just taking over our job. They're not doing what they need to do, which is basically following the orders that the doctors write. I heard that from about a third of my medical residents. A third of them loved it, and then a third of them were kind of agnostic. So fast forward a little bit. This experience for me, by the way, pushed me out of the boat. It pushed me out of the church of IPE. I said, I will never, IPE is a fantasy, idealized notion that is being mapped into a healthcare system that is just not built for it. And the learners don't like it. And I took a hiatus from IPE for 10 years. In the midst of those 10 years, the world around me grew up and got more sophisticated about interprofessional education. This organization was one of a couple that were born in around 2010. So in 2010, you'll see the kind of renaissance of interprofessional education in the United States. So this was the Interprofessional Education Collaborative. It was spawned at the national level and included membership of the major professions organizations from most of the health professions commonly involved in interprofessional education. And they set about trying to lay the foundation, lay a framework for what this is all about. They came up with this model, which puts an effective collaborative health force at the beginning, right in the middle of a journey between health education and health outcomes. They designed a curriculum, and they outlined about a 5-point major curriculum that's probably familiar. It has to do with knowing how teams work, respecting our colleagues, understanding what our colleagues do, and being ethically and professionally appropriate and respectful. At about this same time, I don't remember the year, so this was the University of Michigan, which actually created its own interprofessional education center. It was funded centrally. It came from the provost at the top level as well as the departments. So everybody had to kind of kitty up, put some money in the kitty to create the beginning of this Interprofessional Health Education Center. The Interprofessional Center, IPE Center at the University of Michigan, adopted the competencies from the national organization pretty much straight up. The 5 components are values and ethics, which has to do with professionalism and respect. Understanding the roles and responsibilities of what other folks are. It is common for medical people not to understand the scope of responsibilities and authority of social workers, pharmacists, and nurses. It is common for medical residents and even physicians to not understand the breadth of skills that licensure covers, or social workers who do mental health counseling, pharmacists who can do direct care and therapy, and nurses who can provide primary care. Communication skills, how to listen, how to speak, how to be listened to. Teams and teamwork, and then intercultural intelligence. And they did a nice thing. They added this in, that intercultural intelligence is a mindset. It's a set of information and knowledge. It's a skill set. It's the ability to do things like interact with others from other professions. And it's a heart set. It's an openness to being wrong. It's an openness to being corrected. And it's a willingness to move forward with others. All of those turn out to be essential components of interprofessional care. The question remains in the United States, where and how should interprofessional education actually be taught and learned? And I'm going to create 3 themes here to think about: classroom-based education, clinical practice-based education, and community-based education. And I'm particularly interested in how the HIV program and its interprofessional education here fits into this spectrum. So it turns out that classroom is the way health educators think. Our interprofessional education has taken classroom learning so seriously that once a year now they gather every health profession student from the first year in pharmacy, social work, nursing, medicine, and maybe others. And they gather them in one place at one time, and they have this gigantic single session. As an educator, I have no idea whether anything good happens there. But they do break it down into small groups. But this is actually in an arena. This they have to hold this in a sports arena to make all those room for all those folks. But this is their way of engaging students up front with students from other health professions. They do a case study that people work at in small groups. They bring in famous people to talk about cases. So this is my complex care team. Right, so this is the care unit that I'm privileged to be a medical director for. And they ask us to bring one of our complex cases, one of my personal primary care patients, to the podium. And the entire Chrysler Arena talked about how we, nurse practitioner, social worker, dental, pharmacy, all work together around, right, 2 social workers, 1 mental health focus, 1 general coordination of care focus. Every one of these folks is involved in my patient. So that's the classroom-based, this is to highlight the questions and answers around the classroom-based. Turns out that classroom-based education has some strengths and weaknesses. Learners traditionally will tell us that they value learning about the other professions. You can do that in a classroom. What does it take to become a pharmacist? How many years of training? What's your scope of service and responsibility? Oh, so that's what that means. Oh, that's the difference between this kind of nurse and this kind of nurse. Those are unknowns to most people, at least from the medical side. So classrooms are great for that. But it turns out that they're not great for early skills development, attitude development. You have to think about the clinical setting. So, enter experiment number 2. Through my complex care program, where we reach out to folks who are usually low-income patients in poverty. They're oftentimes seen recurrently in our emergency room. They're oftentimes homeless or precariously housed. They're oftentimes engaged in chronic mental health or substance use services. We reach out very explicitly to those folks and try to bring them into care and provide them coordinated care. I thought, and I was so frustrated with our attempts to care for our patients in a system in which The care providers weren't talking to each other about that same patient. The inpatient team didn't know what the outpatient team was doing. The outpatient team didn't know what happened to that patient when they came in and out of the emergency room. I was so frustrated with our challenges in getting our own team members to talk to each other. I thought we could create an IPE program at complex care in order to help energize the system to see itself. We took a very anthropological view. We brought students into our complex care center, and we asked them to, we gave them readings on the power dynamics of interprofessional education, the frustration and voicelessness of many health professionals other than medicine, the blinders that folks in medicine have, the places where it works well. But they were original articles demonstrating from an anthropological point of view how IP care, interprofessional care, actually works in the real world. Well, so we found that students loved seeing the complex care managers relate to the whole patient. They really loved that. They didn't like what we were doing about IPE, though. They said, we've already had IPE because we took this class. We know what that's like. And by the way, what you're telling us about IPE doesn't match our experience on the wards as nursing students where we see doctors dominate. That's not what it's all about. So you're not giving us any realistic information here. Tears were shed in those meetings, too. And we also learned that teaching interprofessional education while doing interprofessional care takes a lot of skill, time, and effort, especially on the part of faculty. We were exhausted. My care managers were exhausted after 2 years of trying this with our students. We couldn't continue it because there was no incremental resource support for us to find the time to continue this intense teaching effort. So let's move to the third frame, which is whether community-based interprofessional education is also, or what are the pros and cons around community-based education in interprofessional education. So this is my experiment number 3. A group of our students started a student-run free clinic, which is in a small community apart from the main campus. It includes medicine and nursing. There's a very strong lead from nurse practice. We have early learners there before they get too jaded and too kind of socialized by the rest of the system. And we found that the learners love it. They find it's immediately relevant because they're seeing patients for whom the interprofessional team matters. And it's obvious to them that the kinds of needs that the patients have make a difference by having the professionals there. They have a social worker or a pharmacist to turn to right on hand, and they can walk into the room and meet the needs of that patient. And then experiment number 4 was here. When I learned about the Cobras program at MUST, the Community-Based Education Research Service Program, and I recognized that's a national program, and I recognize there's a deep history here with Cobras that I'm admittedly ignorant. I want to make that caveat. The piece that I saw was what's happened at MUST, and I instantly recognized it as a place for interprofessionals to learn from with each other. And so I wanted our learners to participate in that. So we did that. And we found that our learners loved it. They were learning with Ugandan students in multi-professional, interprofessional teams. They were then working with village members. This is VHT in her home. And they absolutely thrived on it with a little bit of coaching. I mean, it wasn't totally easy. But they found it an easy and natural place to reflect on their cultural consciousness, a ton of stuff about cultural biases. They were able to reflect on the role of social determinants in individual and population health. They were able to make observations and comparisons of interprofessional care across 2 cultures. And we demonstrated through a metric, a scale, an objective, psychometrically sound scale, that they developed more positive attitudes towards interprofessional care for both the Ugandan and the North American students. So this is my last slide. And then we're going to open it up. If I had 4 take-home messages that I wanted us to think about, it's these 4. First of all, students value learning about other health professions, at least in the United States. They routinely come back from these sessions saying, now I understand how a nurse practitioner gets trained and what their scope of service is. Same for pharmacy and social work. Number 2, interprofessional education in the classroom can provide basic information, but not much else. And it can create disinterest if you push it too far. Number 3, interprofessional education in clinical settings can be effective in places where interprofessional care is working well. So I think of your ICU, frankly. That sounds like a place that, and Ronnie and I were talking about ICU rotation here, that sounds like a place where the nurses give report to the physicians. I don't think that happens at our institution, but it means that there's value in understanding the nurse's report, because the nurse understands what's really happening with that patient. And that's routine practice and part of the culture. So where interprofessional care is working well, and faculty have the time and skill to help learners come up to speed. Clinical settings for IPE can be great. In other settings where the interprofessional care team isn't working well, or there's not time and energy to help learners walk themselves into this headspace, it doesn't work well at all, and learners can become disinterested. And finally, interprofessional education in community settings may provide some unique advantages over doing it in healthcare systems, because in community settings it appears that students and learners are most directly faced with the challenges across the entire spectrum of need, from social determinants, public health, to acute care, disease bases, and triage. It's all happening right there in front of their eyes. And so my hypothesis personally is that context provides a springboard that is very powerful for learning and skills development in interprofessional education. So with that, I'm going to stop. Joe?
Thank you, Brian.